Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2019. It's day 5, and we are here with Dr. Franson for an extended Q&A session. Let's listen in as she addresses your unanswered questions.
So in today's session, I talked about using what we know about cannabis to try to advocate for both patient and user safety. But we had a lot of questions because it's really difficult to cover everything in such a short amount of time. So let's focus on some of the questions that we got that I wasn't able to answer. So one of the questions starts out with, can you comment on patients who are using CBD and purity of oil? And I can talk about that. So one of the things I mentioned is that last year, 2018, there was 75% of all CBD sold in the United States came from China. And what we also know is that those products had poor purity, had contaminants, had pesticides, and maybe even solvents that were carcinogenic. So what I tell people, if they're going to buy CBD, do not buy it from the local gas station, a convenience store, because although these products are cheap, really what's in them is unknown, and you may actually be getting some THC in it. So what I recommend is you go to your local dispensary and you ask for as pure of CBD as you can get. And you need to be careful and ask, particularly if you're in a situation where you are going to be drug tested, you need to try to figure out how well they're purifying that CBD away from the THC so if you don't lose your job if you have, let's say, a positive drug screen. Is there a strain of cannabis that has high CBD and low to no THC? If so, where and how can it be obtained? Well, this is actually interesting because the first strains came here from Colorado Springs, where we are. Charlotte Figley was the small child that had the intractable seizure disorder, and she was able to obtain the product from a local dispensary. However, when you look at transporting CBD and possibly some THC across state lines, that's federally illegal. And so the recommendation that I have is that you try and obtain a high CBD, low THC product from a local dispensary. Again, just because you can go to that dispensary and ask the important questions about how do I know what are the pesticides that are on this, the impurities, maybe the solvents that were used to obtain the product, and how regularly are they testing their products for any contamination with THC. You can't do that when you mail order something online. So develop a relationship with a local dispensary is probably the best thing I would tell patients. What placebo is used in cannabis trials typically, and is it really blinded for the subjects? That's a great question, right? Because we know what cannabis smells like. Well, it turns out that we can do blinded trials. So when we did our trials in the Netherlands as well as here in Colorado, we would typically blind the products, the placebo products, by using either heavy tangerine smell and aromatic oils or putting tangerine flavoring in the oral products themselves. For some reason, the tangerine has the right mix of terpenes that confuse the smell, and patients have a more difficult time really differentiating products. So the next question, can you please weigh in on the use of pure cannabis oil for the treatment of cancer? Well, gosh, as I mentioned in the talk, that there's several states that have created legislation that says that patients can utilize cannabis for the treatment of cancer. But in reality, what we're really seeing is the best evidence is treating either cancer pain, treating the nausea and vomiting that's associated with chemotherapy. And there's some evidence that it improves weight, but it's not as good as the other two. So when we actually talk about treating cancer, the reality is the best evidence came from some mouse trials in Spain. And what they did is they had a glioma. They had mice that had gliomas, and they would place a THC wafer on the glioma in the brain and look for a response. And sure enough, many of the mice ended up surviving and their gliomas dissipating over time. So it looked like THC was the answer to treating some brain cancers. Well, in the end, what ended up happening is there's been intrathecal administration of THC to human patients. And the reality has turned out that there's not been, in one trial of I believe it was 9 patients, there was not a response. And then there's been a subsequent trial looking at using ingested form of cannabis that had THC and CBD in it. And that particular trial showed that there was a small increase in length of life. And when I mean small, it was a couple of weeks. But it was there. So I can't comment on just using pure CBD because the data that has the best evidence has THC as well. Is it true that current marijuana is considerably more potent than previous decades? Yeah, absolutely. So if we look at the percentage of THC, which is, again, the most psychoactive, but also the most medically proven to be helpful, we know that THC concentrations in the leaf product has increased from maybe 3 to 6% THC to now you can get a strain called sour diesel that has like 30% THC in it. So generally, yes, that answer is true. But it's not to say that you can't go to a dispensary and obtain concentrations of THC that are reasonable. But the reality is we need to really change the dialogue about concentration. We need to start helping patients understand what different concentrations of these products mean. For example, everybody knows that what is the serving size of a 6% beer compared to a 14% wine compared to a 15% alcohol, right? We know how much you take in varies based on percentage. And we need to start having these conversations and educating the general public on what different concentrations of THC means. So if you purchase a 30% THC sour diesel strain, that you know you should use less of it in order to obtain the same dose as you would need from a less potent cannabis product. But I got to be honest with you, I teach pharmacy students how to do these kinds of calculations for a variety of drugs all the time, and it's hard math. But we need to start making people aware what it really is meant by potency in different percentages and relating that to the amount that's taken in. What is a language we should be using to evaluate how much is using then? Well, the idea behind this is that when you speak to your patients, ask them, have you tried using cannabis and are you currently using it to try to treat your disorder? The next question needs to be, what kind of cannabis are you using? And I don't care about the indica and sativa, as I mentioned in the talk, but rather you need to ask, do you know the specific percentage of THC compared to CBD in your product? Do you consistently use those percentages? And if so, how much are you using every time that you dose yourself? Because again, that starts to get at dosing, a milligram percentage. The other thing to ask is, how are they using it? What is their route of administration? Because this can also help us understand, are they reaching those really high concentrations you'll see from vaping and in inhaled routes versus the oral routes? And then, of course, I feel fairly dubious about a lot of the topical products. So what is dabbing? Is it the same thing as wax, shutter, and butter? And the answer is not really. Dabbing is a process. It's the way in which to get the super concentrated forms of cannabinoids called wax, butter, or shatter vaporized. And so remember, when we dab something, we're going to superheat that nail with a blowtorch, put a glass globe over it, and then inhale it through a bong, okay? So the biggest thing to recall about this is, why are we using, or why is our cannabinoids in the wax or the butter type form. And that's because they're so high concentrations. They're probably greater than 90% cannabinoids. And so when patients are using this, recognize they've become super tolerant to the effects of the cannabinoid. So this brings us to our next question. Please comment on synthetic cannabis. So synthetic cannabis are other compounds that have been synthetically made and in general are 100% full agonists at the CB1 receptor. They are not synthetic cannabis for CBD, but rather more THC-like products that are going to hit the CB1 receptor, but instead of being a partial agonist like our endocannabinoids and THC are, they're going to over-affect that receptor. And so because of that, we see a lot more problems with psychosis and hallucinations. Is there any concern of developing serotonin syndrome when taking an SSRI with medical marijuana or CBD oil? Not really. All you're going to get is elevated concentrations of a serotonin product. And as you know, even if you just have one serotonin product with really high concentrations, you're unlikely or less likely to get serotonin syndrome. It's really when you have kind of two different serotonin agents working together that you see it. So just because you're super therapeutic on one product does not typically lead to serotonin syndrome. The last question has to do with talking about utilizing a product, CBD, THC, in young patients. And it's something that I'll expand on quite a bit in my response. How would you advise a friend who wants to use CBD gummies for her 7-year-old child with autism? Because the patient's mother says it calms her daughter down. Well, the reality is there's a lot of data that we already have that tells us that when utilizing various cannabis products early in life, that this leads to problems with cognition, leads to problems with increasing suicidality, leads to problems with increasing psychosis, and I don't know if I said it already, decreases problems with cognition and decreases their patients' IQ. Because of this, when the national academies looked at evidence for using different kinds of cannabinoids in things like autism and ADHD, they actually didn't find any help with autism, and with ADHD, they were more concerned about the increasing risks of substance use disorder. So we don't have a lot of evidence. Now, granted, everything I just told you is based on data from THC. So when we talk about CBD, we don't really know the risks. Patients who use Epidiolex for their intractable seizures, these tend to be very young children because often patients who have these disorders don't survive into later in life. Why? Because they're having 200 to 400 seizures a day and they just can't develop over time. So when we look at the risk-benefit of using a CBD-like product in them, anything that decreases the seizure frequency is considered helpful and less of a burden than the actual disease itself. So therefore, that risk is worth it for that patient population. The question with autism could be the same thing. What is likely to be helpful, how is that child going to develop over time, can be in question. But because it's not a progressive disease with autism, I would say that due to the risk, it might be a risk you do not want to take because we just don't know anything about long-term CBD use in pediatric patients.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Congress 2019 and make sure to subscribe.